Hi, I'm Tyson Franklin, and welcome to this week's episode of the Podiatry Legends Podcast. The podcast is designed to help you feel, see, and think differently about the podiatry profession. With me today is James Ferrie. James is a musculoskeletal podiatrist, and he specializes in diagnostic ultrasound and shockwave therapy, which is what we're going to talk about today. Now, if you want to know a bit of background about James, go back and listen to episode 368. This is where we spoke a little bit about how we got into podiatry. And in that episode, we were talking about point of care ultrasound. So finish listening to this one, then go back and listen to the other one, then come back and listen to this one again. So James, welcome back on the podcast.
Thanks for having me back, Tyson.
So today we're going to be talking about shockwave therapy and different aspects of it. And you've recently returned from the national conference where you were talking about it there as well. And I mentioned I knew a few people who were eager to see you at the conference and go to the workshops.
Yeah, it was great. We ran 2 workshops at the conference, which were, I said, look, I generally like to keep the talking part of the presentation pretty light.
Yeah.
And spend a lot of time just showing more those tips and tricks, because there is, I think a lot comes down to the sort of technique and the way there are a lot of things that you can do to make the treatment more tolerable, which ultimately leads to better outcomes. So the best sort of comments that I get from people is like, I learn a lot of little just tips and tricks that I can take back and use in the clinic like the next day, because often you go to some of those conferences and get to the end of the presentation and we need more research in this area. If I can give someone some tips and tricks that they can take back into the clinic the next day, which will have an impact on how they treat patients, that's a good outcome.
The best talks are the one where you will learn something on that day and they don't finish with, we need more research or this is inconclusive. They say, this is what we're doing. This is what you could do at work on Monday. See what results you get. Give us some feedback, because the more feedback we get from people as a group, the more we're going to learn from each other.
Massively. And the thing is that Shockwave, I think I first started using Shockwave 14 years ago. And you look at the number of patients you probably treated in that period of time. It's literally thousands of patients that I've treated over that period of time with it. So you end up getting a lot of data. So I think as clinicians as well, although we might not be researchers, we're literally we're effectively practicing. We're doing with our patients. We're applying an intervention. We're assessing the outcome of that intervention. We're modifying our treatment plan and approach. And we literally do that every day with every patient. So we end up developing a lot of data. And then you start to work out which patients it works better on, which patients, the timing you need to alter a little bit. So they're probably some of the things I tend to focus on. It's like, what were some of the things that took me a while to learn? And a lot of that was just through trial and error. You work out which patients work at which presentations work really well. And a lot of that comes down to the timing. So I think that it's not always whether the intervention is right or wrong for that patient, but the timing makes a massive difference. For example, when you see a patient who presents with like a really acute tenosynovitis, tendinosis, intrasubstance tear of tib post, right? If you progress them straight to an aggressive rear foot correcting orthotic in that first 2 weeks, they're not going to tolerate it. You have to stabilize them first, and then you can progress them through. So sometimes Shockwave is very similar as well, in terms of there are certain times that you can, when you introduce it into that treatment plan, I think makes a big difference.
Okay, so some people you would say are using it too early and not getting the results, or they're waiting too long?
No, so what I generally find is, so what most clinics will have is radial shockwave.
Yeah.
And radial shockwave is the device that has a compressor. You hear the compressor go, and what it's doing is it's sending air to the handpiece and it's firing a projectile back and forth. And as that projectile makes contact with the applicator tip, it's generating an acoustic sort of pressure wave that with ultrasound gel penetrates into the body. What makes a difference is that when we see, say, Shockwave works really well for degenerative type conditions like tendinosis, fasciopathy, and even now there's a lot more. We know that Shockwave's been used a long time for particularly focused Shockwave around bone type pathology like delayed union, bone marrow edema, and even increasing evidence for osteoarthritis. That's really, NEOA is a really big area that there's more and more research that's coming out in. But what makes a difference is it's really the stability. So you might see a patient who has, for example, really stable plantar heel pain. And what I mean by stable is, think about that sort of real classic presentation. It's that Post-static dyskinesia, it's that first step morning pain. The pain warms up as the day goes on.
Yeah.
Get up in the middle of the night to go to the toilet and it's sore, but then they're basically not getting nocturnal pain, and they're not really getting pain that's like persisting through the day. They might have a little bit of an ache here and there, but it otherwise warms up. These patients are great candidates for Shockwave at that stage.
Okay.
Now, where sometimes what happens with those people is because the fascia is degenerative and it alters its biomechanical properties, those patients can incidentally over a few days, they might mow the lawn, they might be renovating up and down ladders, they might even just be on holidays and spend a lot of time on their feet. And then all of a sudden there's this big escalation in symptoms. So the pain becomes less stable. It's no longer just that sort of pain first thing in the morning. Now they're walking down to your clinic room, they've got that antalgic gait, they're complaining that it even throbs a bit at rest. They might even have a little bit of nocturnal symptoms. The good thing with having ultrasound, as we talked about in the last episode, is when you ultrasound these patients, they inevitably have some intrasubstance tearing or some delamination tearing of the fascia. So because it's degenerative to start with, it's a bit weaker, it doesn't have the same capacity from its take load. So when you overdo it and that load exceeds what it can take, you get tissue damage where you get tearing or fraying and delamination. And even though it's degenerative, that sort of tissue trauma creates like an acute flare in the tissue. So you get an increase in all those cytokines that make everything really sensitized. So your substance P, all those neural peptides, some of your prostaglandins and so forth. So even though it's degenerative, you can get this inflammatory flare. So you see these patients that present with an acute on chronic. So they might have had heel pain for 6 months.
That's what I was saying. So you're talking about the patients that I've had this 6 or 12 months and it's only ever bothered me getting out of bed. Then it's never been a problem. And now
it's really sore.
Yeah.
Right. Now, the issue with these patients is because of that change, it's like a cytokine soup. So everything's really angry. And what it does is it creates a lot of like local sensitization in the tissue. So it means a lot of things start to hurt. And these are the patients that the practitioners will find, like the podiatrists, the physios, and so forth. When you try to treat these patients, they're really difficult to treat because radial shockwave has that sort of mechanical irritation. And when the tissue is really sensitized, they don't tend to tolerate it very well. And you find these like up and down responses. So sometimes in those patients, you have to stabilize their symptoms first, and then you introduce it once the symptoms start to stabilize again.
Yeah, that makes sense.
Yeah. So these are the patients you might need to look at taping them, orthotics, shoes, all of those things to bring them down from that sort of 8 out of 10 pain down to 5, 6.
But you wouldn't
4.
have anyone, well, I suppose. Have you had anyone who's just trying to apply a shockwave to someone with, like, when they're in a lot of pain, like you were just talking about, to put shockwave on it would be almost unbearable for the patient?
Yeah, it is. And there are some patients that have had some pretty unpleasant experiences.
Yeah.
And that really turns them away. So I sometimes see patients who'll come in and say, listen, I've had shockwave, it was terribly painful, it didn't help, so forth. And some of that is just the timing was wrong. And then it takes a little bit of time to reintroduce that as a treatment option once you stabilize their symptoms. And then at that phase, you can have a different outcome. So the same intervention can have a different outcome based on where that patient is in that sort of journey and what's happening from a biological point of view. Because you got to think, I think, it doesn't matter whether you're using orthotics or something, you got to think about what you're trying to achieve with the intervention. And this is where healthcare, dietary, medicine, these are not hard sciences. There's just as much of an art as there is a science to it.
Totally agree.
You know, there really is an art to clinical practice, and it can't be always summarized in an RCT, because an RCT is looking at averages by and large. So you're looking at averages, and as good clinicians, all we're trying to do is to find which patients with this presentation are going to respond favorably to this versus this, and that's where a lot of that comes into play.
Yeah, and I think sometimes too, it's got to do with your experience of, one, getting a good history from the patient, asking the right questions, where someone who may not have been out for a long time, they're not sure of what to ask. So therefore, they're not getting the correct feedback. But I think with experience, that just gets better. And which is why younger podiatrists, they don't want to being mentored by somebody who's been out a little bit longer, or at least networking with them and asking these sort of questions and not feeling dumb about asking questions that you're not quite sure about? Because I reckon the only dumb person is the person that doesn't ask the question and then keeps doing the wrong thing.
It's true. And I think as well, like I remember the first year of practice, it's absolutely exhausting, like mentally exhausting, because you're basically seeing things that you've only really got a bit of a theoretical understanding of. You might have seen a little snippet of, you might have had a placement on private practice where you saw a little snippet of a podiatrist treating in one consult, one episode of that patient's care. But some of these things, they're a journey. So those patients that have that sort of really acute or chronic presentation of heel pain, that is a 3 to 4 month journey for most patients. And as a new grad, you don't know that. So you don't really have an idea of that time frame. And that's hard because you can't set expectations with patients if you don't know where it's going. And if you don't set the expectations, patients ultimately set their own expectations, and then you're on the back foot.
So with someone who is a new or recent graduate,
yeah,
what advice would you give them?
So it's true. Look, it really is. I think it really does help when I don't think mentoring can be done in an online space, because people just don't feel posting things on forums, and you can have WhatsApp groups and stuff like that. It's not overly helpful, because when you're new grad, you need someone who you can actually speak to. And that can even be someone who is at the same level as you, but also having someone who's got a bit more experience, where you can actually pop into their room or walk down the corridor and say, I'm not really sure on this prescription or this presentation. Can you come and have a look? And they can just pop in and give you a bit of a pointer. That's really the hard thing with that sort of solo practice, when you're new grad and you get thrown into a room where you might be just working on your own in complete isolation. I think what happens to a lot of new grads is they get overwhelmed by that. And once you're overwhelmed, you start to feel like you just don't have that sort of solid grounding. And I think we lose a lot of, what would be good clinicians, podiatrists, physios, to people that, to jump into a clinical situation for your first job where you just feel a little bit out of your depth, you don't have that support, you feel overwhelmed, and it just creates people start to feel anxious, they don't want to go to work, and then all of a sudden they just drop out of the profession and go and do something different, whether that's in a government job or along those lines, where they try and utilize that skill set. But we do lose a lot of really good clinicians to that.
Yeah, I also think it's one of those things, but like people leaving the profession, and we've done a couple of podcast episodes on it, like why I left podiatry, and they have been two of the most popular episodes on the podcast. But then you get this argument between employers and employees where they're saying, oh, they're asking for too much money. But then when I interviewed a whole pile of graduates from QUT last year, the year before, only 1 out of the 6 or 7 said money was even an issue. They didn't really care about it. They just wanted somewhere where they could learn. They wanted to be better.
Yeah.
And I do think there's some podiatrists, I just want to get paid the most. And if they don't get what they want, they then go, well, I'm going to go and work for myself. And therefore they don't get the mentorship from anyone. And I think after a couple of years, they end up leaving as well.
They do, because it can be sort of isolating. I work solo, but for the first 6 years, I worked in a group practice where I had those sort of conversations. And you do have to seek out mentors. Like I was really lucky enough that as part of that group, we had quite a bit of involvement with Mark Gilheeney. And I'd have to say, look, he really, we've worked together in his practice in East Melbourne before. And just those sort of conversations we have in between patients, the lunches you have sitting down in the office, and the discussions you have, and they're always pretty robust. Both have a very similar style of almost arguing over things in a friendly manner. But that sort of watching people who are really good at their craft is really important, because part of that is also looking at how they conduct a consult. That's really important, how you structure a consult, how it flows. Because if the consult doesn't flow and you're going back and forth, one, the patient doesn't really know where they are in that process.
Really important.
But it's also disorienting for you as well. And that's how you get behind in terms of time and time management and all of those things. So I guess watching the way good clinicians communicate, how they hold themselves in a consult, how they talk to patients, how they provide that education, those things are, you don't learn those things at uni. Uni has only so much things they can teach you. They've got to give you they've got to try and jam pack in 4 years the basics to get you going. But there are a lot of things around sort of communication and stuff that you almost have to learn from observing and watching really good clinicians, and you pick up a lot of tips and tricks and things that come along the way. So there are definitely people that, and if you don't have that, it is hard to feel like you're a bit alone.
Yeah, but like you said, that is exactly why people run behind. I know when I used to take my patients through, and say they were booked in for a 45-minute consultation. So they were a new patient, we were doing a MSK assessment. I could, without even looking at my watch, I knew we were at the 35-minute mark because I knew exactly what I did at what time with a little bit of leeway that you could just work all the way through. Always ran on time, never ran behind. In fact, the goal was to always finish about 5 minutes early so you'd have a little bit more of a chit chat. And I'd try and teach new graduates, just stick to the system, just run through this process. You'll never run behind. And whereas I think people who run behind constantly, they don't have those processes in place. So new graduates, I think this is absolutely fantastic advice for them. And if they don't have a mentor, go and find one. Go, even if there's someone, there should be someone close by that you can go and visit.
You can. And you know what? What's really good as well, where I am over in Essendon, the podiatrists that I work around are great podiatrists and really collegial as well. Like we refer patients. I'm okay with some basic ped stuff, but it's not my area of expertise and passion. So for the more complex stuff, there's two pods locally that love that stuff. They work in a lot of pediatric stuff. They work at some of the hospitals and also in private practice as well. So happily handball those across. And they also happily handball a lot of cases to me. We catch up for lunch. Like I catch up, there's a pod he's only a few kilometers down the road from me. We got up for lunch probably 2 months ago, and we catch up at the conference and those things. So I think it is, even though we work together, it's just such a big market. We're not really in competition with each other, and do enjoy not feeling we're not working against each other. It really makes a big difference because you can call those people up if you don't have something, you need to send a patient across, you're going overseas for a while and you're not there. You can always having those sort of relationships where you can say, listen, go and see such and such, and I know you're going to get good care there. It is really helpful. So I think as new grads, like don't feel, even if you might work quite close locally, if there's a experienced like podiatrist or someone who you respect quite locally, just call them up. There isn't that necessarily, like I think there isn't that animosity amongst people that are close by.
Yeah, I think it's having that mindset of abundance, not scarcity. Where there's plenty of patients out there, heaps to go around. If you're doing a good job, you're always going to have patients walking into your clinic. I remember when I first graduated, one of the things we were told, I don't know if it was an association rule or it was just an urban podiatry myth, but they said if you moved into a town and set up a clinic, you should go out of your way to go and meet and greet all the existing podiatrists in town. That is the professional thing to do. Don't just rock up and put up a sign and be a surprise. So every time I opened up in a town, I always went out of my way to go and meet and greet the other podiatrists. I wasn't always met with a smile, but at least I went out of my way. But when I had my clinic in Cairns, the amount of podiatrists that came through Cairns who opened up, who never said hello, they just opened up, kept away from me, and I wouldn't even know if I met them in the street.
That's it. And you know what? When I was a student, I did placement with Bernard Comerford and Dan McManus, and now they're both still there. And then also Matthew Mollica, and these are really good podiatrists, and Larissa and James Short, and all those sort of pods that when I was a student, they were podiatrists that gave me the time and had me into their practice. And I'm really grateful for that. So that all goes towards making you a more rounded person. So yeah, it is good to have that abundance mindset.
We should get back onto Shockwave.
We should.
I love tangents. I love going off on a tangent, especially when it's a good tangent. So now we'll get back onto the subject. Where are we at with the Shockwave?
So Shockwave, as I said, look, we talked a little bit about radial Shockwave, and that's what most clinics have. There is also focus shockwave as well. So focus shockwave is probably something that I've incorporated into practice probably about 5, 6 years now. And focus shockwave is very different to radial. So if you think about that noise that comes from radial, because you've got that projectile that's hitting that applicator tip, and that's
Yeah.
what a lot of patients are really familiar with. Focus shockwave is different. So with radial, the highest amount of energy is at the skin. And then as that energy sort of propagates into the tissue, you lose a little bit of the energy. So radial is really good for treating a lot of superficial tendinopathies. So probably up to about 2 centimeters.
Okay.
But after 2 centimeters, even though the pressure wave continues further through, in terms of having enough energy to create those cellular changes that we want, you start to lose some of that. Focus shockwave is where we start using higher amounts of energy, but the difference is that the energy converges on a point, and we actually set the focus depth. So we can change when you're treating deeper structures, we can change the area that we're treating. So focus shockwave is a bit different. There are different ways of producing it. So the one I use is like a piezoelectric. So
Yeah.
it's effectively a bit like an ultrasound transducer, but it's created in a bit of a concave, effectively like a lens. And what happens is it sends a lot of voltage, like about 10,000 volts to these 250 little crystals, and they create a really rapid contraction, and all your energy converges on a specific point. So if you look at all the energy, all the research as a whole, there's not like a real clear consensus that says like focused is better than radial, radial's better than focused. What it really comes down to is like the dose you get. Are you getting a sufficient dose? And I think this is where you start to get a little bit more sophisticated. So most people, which is the manufacturers, want to keep it relatively simple so
Yeah.
that you put it on there and you just dial it up based on patient tolerance, which is exactly what you've got to do. But having an idea of, if you look at the research, there is almost like dosage ranges that we want to get into. So if you're in a suboptimal zone, you're not necessarily going to have that clinical effect that you're looking for. You might have an analgesic effect, but you might not be in the right realm to have sort of a regeneration or that regenerative effect in terms of resolving that long-term condition.
So most podiatrists, though, would have radial shockwave.
Yep.
How many have actually got the focus shockwave at the moment?
It's not many. I'd probably say you have like 99% would have radial at the moment.
Yep.
There's a few clinics that have focused. They're different in terms of technology. So the cost is different as well.
Okay.
And that tends to be, so for your average clinic that's just getting into it, your radial is going to cover 85, 90% of the conditions you're going to see. So if you're primarily treating some plantar fasciopathy, some Achilles tendinopathy, radial is going to cover that. It also works really well for myofascial stuff, radial. If you're going to start doing a bit more of the non-union fractures, you're starting to use higher amounts of energy. And as I said, some of those acute on chronic cases, I will actually use the focused because we're able to, there's no mechanical irritation. You don't have any of that sort of sensation of banging. The energy is a deep sensation. Like you feel nothing at the skin.
Okay.
Even
but they feel it deep.
They feel it deep. Even though they are both shockwave, they feel completely different to the patient.
I've never used the focus one. So is it still multiple
No,
hits?
it's still multiple.
But it's a deeper setting.
Yeah, it's different. So you either have a piezoelectric, you can have electrohydraulic, you can have electromagnetic. So there's different ways. So they're all a bit different in terms of how they produce it. So your piezoelectric is using like an ultrasound transducer, and it's creating a really rapid contraction, but all your energy is converging on a specific point.
Yeah.
So what you do is, because effectively the handpiece is set at a set focus depth. So say the one I use, it's set at 4 centimeters.
Okay.
That's where all the energy is going to be maximal. So what we use is these gel standoffs that hold the applicator tip further away from the skin. And that way you're then able to change which depth you're treating. So we could treat it 1 centimeter, 2 centimeters, 3 centimeters, and that's where the maximum amount of energy is going to be. But there's still a therapeutic zone around that. So you're actually almost creating a little implosion in that area, and then there's a shock wave that emanates from that.
Ooh. So you said about 14 years ago that you had the radial one. When did you start using the focused?
Probably about 6 years ago.
Okay.
And I almost always use them in combination together. So I find that for most conditions that I see now, I would use a combination of focused and radial, because there's a lot of advantages to the radial around myofascial stuff. Focus just isn't very good for myofascial stuff. And you're also limited in terms of the frequency or how many shocks it can deliver per second. Because the energy is higher, we're using a lower frequency range. So the maximum will go up to maybe 8. And part of that is because if the frequency goes up too high, it's more from a thermal point of view because you're creating rapid changes in pressure. So I'll tell you a bit of a difference. So say with your focused, in that focal zone, which is relatively small, but even though the focal zone is relatively small, there is an area around the focal zone which is considered our therapeutic zone. And this is where there's a significant pressure change which can elicit those sort of cellular responses you're looking for. But the focus zone, when the device is up relatively high, it's got the equivalent pressure for 10 nanoseconds of 11,000 meters underwater. So you think about that Titan sub that imploded going down to the Titanic, that was close to 4,000 meters. We're talking about magnitudes of pressure, like more than twice that amount of pressure that you're able to deliver with focus. So it's quite significant pressure. So this comes from more your lithotripsy. So lithotripsy is using really high energy to try and fracture kidney stones and renal sort of calcification. Now we're working in a different zone. So with focus,
wasn't that how it was all first developed too? Was it? It all came from that.
It did. So it come from the in the 80s. They were using lithotripsy to effectively break kidney stones, and then what they started to find is that there's just some observant doctors that were doing that procedure started to notice there was patients reporting that they were having improvements in back pain and other musculoskeletal pain.
Yeah, I'd heard that.
And then I think what probably happened is back then, you think about in the 80s, there wasn't really any MSK ultrasound. There wasn't any easy access to MRI. So for most people, they were looking at spurs. So they probably had a thing that they were going to break the spur up with lithotripsy. But we know that when we're looking at tissue regeneration, it's in that medium range. So in the really high range, we use higher energy for bone pathology. But in the medium range is like that optimal zone for getting tendons and fascia to heal. If it's too high, it's not helpful. And if it's too low, it can have some effects in terms of a bit of angiogenesis, a little bit of pain reduction, but there's a bit of a dosing curve in terms of depending on what you're trying to achieve. So at really low levels, you get a bit of analgesic effect.
Yeah.
And then if you are using your focus device too high, you actually start to cause a little bit of inflammation. So if you're treating really bony pathology, we want to treat with that higher energy. But for tendons, there's an optimal sort of medium range that we want to get into.
So with the protocols that you've come up with, are these things that you've worked out yourself, or is this literature you've read through and then applied it, or is it a combination of both?
Both. Actually both. So an example is, so what I tend to do is like some of it is, as I said, with the radial stuff at the start, a bit of it's like trial and error, like how I worked out which patients, like those acute on chronic patients, they're not great candidates until you stabilize them.
Yeah.
The way I worked that out was I treated a lot of those patients and I found that it was a bit hit and miss. And then I found that if I was able to stabilize them first and then treat them, I got a completely different outcome. What you look at is I look at a combination of the research and you look at the sort of dosages they're using and you look at which studies have been successful and unsuccessful. So the unsuccessful studies are just as helpful. So
you mentioned one off air before I press record.
I can give you a bit of an example, right?
Yeah.
So there was one that some people might have seen pop up, and this was published earlier in the year, and it was on insertional Achilles tendinosis, and it was a 12-week trial. So what happened was they effectively broke up. I think they had 37 patients in one group, 36 in another group. And these are patients that with insertional Achilles tendinopathy. Now, what they did is both groups got some sort of loading program, some exercises prescribed by a physio, and one group got Shockwave. Now, it was radial Shockwave, and it was a different device than what I use. And the interesting thing with Radial is a mechanical device.
Yeah.
So it's a bit like a car. Like say, for example, you take a 2-liter Toyota engine versus a 2-liter Porsche engine.
Yeah.
They're both 2-liter engines.
A
They
little bit
both
different.
do something, but they're going to perform differently because it's the engineering that goes into it. One of the limitations with your first generation Shockwave handpieces is because they work by firing a projectile in that chamber. There's a
Yeah.
little barrel, it's almost like an air gun, and it's firing a projectile. As the frequency, which is how many shocks per second it's delivering, as that starts to get higher and higher, the projectile can't make its way back to the starting point. So it starts traveling shorter and shorter distances within the barrel. Now that has a consequence to the energy output. So you get this basically drop off in energy as the frequency goes up. Now, there are the device I use, which is the Dollar class, Swiss made. It's makes up about probably 80% of the RCTs that are listed in the Pedro database. And from a performance point of view, it's the Porsche, it's the Ferrari. It has the highest energy output out of any of the radial devices that are on the market. There's published research. So there's literally there is in the database peer reviewed where they compare the performance of the different handpieces.
Yeah.
And it's because there's some different technology in their radial handpiece. So the device they used was a different device, and it's published. So you get at its highest frequency, at its highest bar pressure, you get a drop off of 92% of the energy that comes out the end. So
Big drop off.
Big drop off. So they treated basically midway, about 10 hertz, and they treated somewhere between sort of 2 bar through to 5 bar. Now, the bar pressure between different devices is not an indication of what's being delivered to the patient. It's the internal working pressure of the compressor. So you can actually go back and you can work out what the energy output that they're delivering is. So say for this study, they come to a conclusion that there was no difference in outcome. So they followed up patients for 12 weeks. The patients got 3 sessions of Shockwave, and they followed the 2 groups up and there was no difference. Now, if you look at both of the groups, there's very little improvement in the 12 weeks overall. So there's not huge differences in terms of outcome measures. Both groups improve a little bit, but not a huge amount. There's a meta-analysis from a few years ago, it was like 2022, that looked at all the research in terms of injection therapy, exercises, Shockwave. And it's funny because it had the opposite conclusion. It said that out of all the research with injections was a bit mixed. Some are better, but there's not overwhelming evidence that injection therapy is overly helpful for your insertional Achilles stuff. There's actually, even though exercise therapy is like a standard of care, there's not a single RCT that compares that against a placebo. And because the difference is so small, you actually in that study don't know whether any of the intervention made any difference. You could have done nothing because it was such a relatively
same result.
Yeah, most things get better a little bit with time anyway. But if you go into the dosing, for example, and you work it out, of the 3 studies that have previously been done that showed an outcome that was superior, what you find is that when you look at that energy flux density, which is basically like the pressure of that shockwave per impulse, all of them sit over 0.1 millijoules, which is now in that sort of medium range.
Yeah.
This study sits between 0.03 and 0.07.
Did that take into account where the patient was on that journey, where you said before?
No, and this is the hard thing. Like you've seen insertional stuff, like that's such a general term. Some of these patients have calcinosis. Some of them have a lot of enthesiopathy. Some of them have retrocalc issues. Some of them have Haglund's deformities.
Yeah.
Some of them have delamination tearing. So it's a pretty broad, and they're all going to have quite different outcomes.
So you could have had that same group of people and got a completely different result based on what settings you used at the time of doing it.
Completely. So if you look at that even at the maximum amount of energy that device was able to produce, and not all the patients would have been able to tolerate it. So not all the patients would have been able to even get up to that potentially, but they're sitting in a dosing range that is more analgesic. You get a bit of that release of substance P, you reduce a bit of that neurogenic inflammation, so the patient feels temporarily better. But it's not sitting in a dose that's going to change you're not going to get a lot of tissue regeneration. And then you also have to look, so that's one factor, But the other thing you got to look at is the total amount of energy that you deliver over sessions. Because what's really interesting is if I've got a patient that's got a lower threshold, you often need more sessions. So I know from a dosing point of view, say for example, if I'm seeing a pretty degenerative plantar fascia, the total energy dose over the course of treatment, I need to get that north of 700 millijoules. Preferably between that up to about 1,200 millijoules. That's the range I want to get in. Now, some patients, I can do that in 2 sessions. Whereas some patients, it might take 5 sessions. If I don't have an understanding of that, you're just like guessing the dose. And that's really made a big difference in terms of, I think, as I've got a bit more sophisticated with Shockwave, it's a bit like a drug. If you're administering it and you don't know the dose, you're just administering it, and as every patient's getting a different dose. Yeah, maybe overall there's going to be a benefit there, but the patients that don't get that optimal outcome, then you turn around and go, what was it? Was it the dose that was wrong, or was it the intervention that was wrong?
But you also said earlier on too, if it's too high, then you can actually cause problems as well.
Yeah, you can be over. You can be over the therapeutic. So you think about like that therapeutic window. With medication, we talk about a therapeutic window. So you can either be subtherapeutic, or you can start to push it to the point where you increase the likelihood of adverse effects.
I think every podiatrist that's had a Shockwave unit has done things to themselves.
Yeah, completely.
We've all done it. And I would say there's been times where I treated a problem on myself, and I would say I overdid it big time. And other times where got it absolutely spot on. But what I like about everything you're talking about is I know there's a lot of podiatrists that have Shockwave units now, that have the Radial ones.
Yep.
I like that, like you've done so much working with patients in this particular area that they don't have to reinvent the wheel. They can just learn from what you've learned. And you've said you've got a course coming up?
Yeah, so with EMS, we have what's called our GDT Summit, which is coming up. We've had the first one. These have been run all around the world, all through Europe, all through a lot of Southeast Asia as well. This is the first one in Australia. It's being held on the 16th and 17th of August in Melbourne basically it's very close to the tennis centre, right in the sort of the heart of Melbourne.
Okay, easy to get to.
And so we're actually flying out Professor Christoph Schmidt, who's a German professor. He's an MD, PhD, and he would be one of the most prolific authors of Shockwave research, getting right back. If you've read any Shockwave research, you'll find his name will come up repeatedly in a lot of the citations and in a lot of the articles. So he'll be doing a lot of the first day, and then the second day is really clinical focus. So I'll be presenting, and a lot of it's case study. So we're doing a lot of case study based stuff, and then we're doing a lot of demonstration, and we're doing a lot of hands-on stuff. You'll have a lot of machines
there, a lot of hands-on stuff that people can actually do.
And look, I'll be there, but we've also got expert physios, we've got expert chiros, so it's really multidisciplinary. It's not just a podiatry conference.
Yeah.
And what I've also done as well is that the full price of that conference is $600. It's a 2-day conference, but I've got a link
cheap
for a 2-day conference.
It is
and
cheap.
I've got a link which we'll put in the show notes, which will allow you to get a $150 discount. So it's like $449. And I'd highly recommend it. As I said, we've got experts from the academic side that will be there, but then we've also got the clinical stuff. So we'll have sort of sports docs, we'll have a lot of clinicians that use this on a daily basis that can really give you the tips and tricks to get the most out of your device. Because a lot of people come to these and they might have had the device for a long time, and the only thing they treat with it is like Achilles problems and some plantar fascial problems. So we start to open up and expand some of the other ways that you can use the device, some of the off-label approaches that we'll tend to do as well for certain conditions.
Yeah, so because I know when we got ours back in 2011, everything was just learned by trial and error. What can we use it on and what can't we use it on?
Yeah.
And heel problems were one, Achilles problems, neuromas we got a really good result with, but that was a tricky one.
It's tricky, yeah.
But once we worked it out, we got really good results with it. So with this 2-day event that's on, how many spots are available?
again, I think we've probably got about a maximum of 80 spots that are
Okay.
available. We're probably over 50% sold out at this point. So I'd highly recommend it. We don't want it to be too big because we don't want it to take away from that
Yeah.
sort of hands-on, and we don't want it to be all just lecture based. We really want it to be something where clinicians come in, they get a chance to have hands-on experience, to practice, to see what it feels like to practice on each other as well, so that you walk back into the clinic feeling more comfortable using that modality. And,
Are you having the radial and the focus, or just radial?
yeah,
I have
radial
both.
focused will have both. There's also a therapeutic laser that fits in there as well for some of the
Okay.
more acute type stuff. But I think you look as a modality, in my practice where it's all MSK, it is something that I heavily rely on and I use. And I would say I use Shockwave now more than I did when I first graduated, because I know where it fits in. And as you get more confident in the results that you can get with it, as a new grad, like, it can be hard to feel like you can, like, a pair of custom orthotics might seem expensive, but the more you use a modality, the more you get comfortable about what you can and can't achieve with it, you become a bit more confident in saying, look, I'm pretty confident we can get this sort of result with that. And I think it's easy to be very academic about things, but when you're in clinical practice and you see patients that are coming in, the patients that are coming in are often outside that sort of, you look at a study that has an exclusion thing. We see patients that are in that exclusion thing. They're not nice, healthy 25-year-old males. We see patients that have a whole bunch of different things that come in, whether it's a metabolic disease and different things. So we have to adapt. And I think that you don't want to be throwing out whole modalities. You want to be looking at what things can you fill into your toolbox, because the patients that we see come in with complicated things, these chronic tendinopathies and fasciopathies are difficult to treat. So we need to have as many tools in our box. That can be rehab and exercise-based therapies, it could be shockwave, it can be injection therapy. The more things you've got in your toolbox to fit in and to help patients along that different journey, I think the better.
Yeah, no, I think it's fantastic. So people have about 4 weeks if they listen to this episode when they should, which is straight away as soon as it comes out. Then they've got 4 weeks before they get in. But I reckon you're going to sell it out pretty quick.
I think so. There's a lot of at the conference. A conference where I was just up there presenting. We had 2 workshops. Both of them were completely full. They were turning away people because the room was chock-a-block. So yeah, there's just more and more users of Shockwave, and there's more and more that sort of thirst for knowledge and for some of those little tips and tricks that can help get the most out of it.
Yeah, and I think for any podiatrist listening to this now, is like when we got the Shockwave 2011, we were the only one that had one. It was years before anybody else. I think I'd sold my clinic before anybody else got one. Now, a lot of podiatrists have got a Shockwave unit, but just because they've got one doesn't mean they're using it the right way or getting the results that they need. And then also marketing it to the other health professionals in your town that, hey, these are the results that we're getting. This is what I can use it for. So I think, like, listening to this podcast, going along to your workshop and staying in touch with you and just learning from other podiatrists, the better they get, the better it's going to be for them, like in their community, in their town, just with their reputation, with using that equipment.
Yep.
So,
completely.
Okay, James, I want to thank you for coming back on the podcast, talking about this. And I tell you, you have an open invitation. Anything else you want to talk about, you have an open invitation. Come back whenever you want, because your last episode was popular. And I know this one will be. And I'm sure anything you want to talk about, people want to listen to. So thank you very much.
Thanks, Tyson. Good to chat again.
Okay, I'll talk to you later. Bye.
See you later. Bye.